You read that slide correctly. It is time to talk about pharmacotherapy for pituitary disorders. Your learning objectives are to recognize the disorders by hormone insufficiency as hypersecretory or hyposecretory, describe how growth hormone abnormalities are corrected, and how prolactin abnormalities are corrected. To understand prolactin, you need to understand the role of dopamine in normal prolactin secretion. Finally, just explain the mechanism of action of the medications discussed. First off, let's talk about growth hormone. Growth hormone is great because its name is very self-explanatory. When growth hormone is released, you get growth. It is going to affect activity at the level of the liver in that we increase stored energy and liberation of energy. We get long bone growth, especially if the physes of the skeleton are open. You'll also hear the physes referred to as growth plates. Growth plates are open until puberty is over, at which point they seal. So we would say during pre-puberty times, we have open skeletal physes, and post-puberty, we have closed skeletal physes. Post-puberty, bones cannot grow any longer. However, they can grow thicker. In the same way trees acquire rings as they get wider, bones can also grow that way. So growth factor after the physes close will get bigger. They will not get longer, but they will get thicker. So bone also responds to growth hormone. Fat cells, adipocytes, they respond to growth hormone specifically by lysine. That's a great way for us to store energy as fat in adipocytes. When growth hormone is released, we break that fat down and we utilize it more effectively. So more growth hormone secretion equals more lean body mass. And that is also going to have effects that are more anabolic in nature on the muscle. So we start to deposit more protein. Growth factor encourages muscular growth in both prepubertal and postpubertal individuals. If we take a look here at things in green, we have things that increase secretion of growth hormone, the primary being the releasing hormone from the hypothalamus, growth hormone releasing hormone, or GHRH. GHRH from the hypothalamus binds to cells in the anterior pituitary so that the pituitary spits out growth hormone and has all of those somatic effects. Another thing that increases growth hormone is ghrelin, and I like to say it as ghrelin because that's what's released when you're hungry. It makes your stomach growl. That's why I like to say it in that fun way. And ghrelin increases growth hormone secretion itself, also by stimulating growth hormone releasing hormone to be spit out from the hypothalamus. An inhibitory signal on growth hormone is also something that's got a pretty good name. SST stands for somatostatin. Soma means body, and statin comes from static, which means to keep in one place. So somatostatin means to halt or stop the body or growth of the body. So somatostatin is an inhibitory hormone on growth hormone. So it halts or stops body growth, SST. Finally, the activities of growth hormone are carried out by activity of IGF-1, which stands for insulin-like growth factor 1. So if growth hormone activities in the body are mediated by IGF-1 effects, that means IGF-1 will serve as the negative feedback to this whole system. So IGF-1 is inhibitory on growth hormone expression only because it is the negative feedback. When we have normal homeostatic levels of growth hormone out in the body, levels of IGF-1 that are homeostatic will signal back to the hypothalamus that we can stop releasing growth hormone, releasing hormone. So if you understand what inhibits and what stimulates growth hormone secretion, understanding how we treat disorders of growth hormone secretion becomes really easy. In the same family as growth hormone, which is called the somatotroph family, is another hormone that is produced by the anterior pituitary called prolactin. Prolactin's got a pretty good name in that we can break it down into prolactation. Prolactin is what drives milk production in the body. The cells in the adenohypophysis, also called the anterior pituitary, that secrete prolactin are called lactotrophic cells. So they are cells that drive the creation of milk. One of the primary stimuli for prolactin secretion is literally suckling. So that suckling can be by the infant who is at the breast. It can be through manual stimulation. It can be through a breast pump. Any kind of activity at the level of the nipple will stimulate through mechanoreceptors a feed-forward mechanism to the brain to stimulate, to increase secretion of prolactin. Because that's a mechanical type of stimuli, suckling turns it on. That also means when suckling stops, that's one of the strongest mechanisms to turn off prolactin secretion. There are two hormonal signals that are associated also with increased prolactin secretion. One is right here, TRH is thyrotropin releasing hormone. So that is a product from the hypothalamus. If it's releasing hormone, that's where it's from. And thyrotropin is referring to thyroid hormone. The cells in the anterior pituitary are really similar to one another, and we'll find that they can sometimes respond to multiple releasing hormones. Thyrotropin releasing hormone, or TRH, stimulating lactotrophic cells is a prime example of that. So TRH increases prolactin secretion. The other hormone that increases prolactin secretion is a little bit more confusing. It's called vasoactive intestinal peptide, which got intestinal right in the name, which in this case just refers to where it's normally found. And it was actually first found in the turkey. So we're not even talking about turkeys right now. That's confusing. We're talking about humans. But it turns out it's also released in the hypothalamus. So hypothalamic vasoactive intestinal peptide, or VIP, also stimulates lactotrophic cells to secrete prolactin. We're not super sure why that is. It's probably shape mediated, but regardless, you should know that that does have an influence on increasing prolactin. So far we've got suckling at the nipple, TRH, and VIP as things that turn on prolactin secretion. With inhibitory signals for prolactin, we have an interesting mechanism here, and it's actually dopamine. Dopamine, or DA for short. Dopamine is a type of indolamine that's made in a lower area of the brain, and dopamine is inhibitory on prolactin. So as long as dopamine is around, prolactin will be inhibited. When dopamine levels are off, we will definitely see abnormalities in prolactin secretion. Because there's just dopamine feed-forward mechanisms to shut off prolactin in the brain, and then suckling is a mechanical stimulation to turn on and turn off prolactin secretion as well, we don't specifically have a negative feedback by any peripheral hormones in this system, which means we're mainly going to mess with dopamine to alter levels of prolactin secretion in the body. When we think about disorders that involve abnormalities in growth hormone and prolactin secretion, they can manifest in a variety of different disorders, but generally we can just put them in categories of excessive or inadequate secretion, so hyper and hyposecratory states. In excess secretory states of growth hormone, we have two different pathologies, and really what differs between them is whether or not the skeletal physes or growth plates have closed. If there are open skeletal physes and there's an excessive secretion of growth hormone in the body, well, then the bones continue to grow. If the bones never seal, they can grow very, very long. If this becomes pathologic, that's referred to as gigantism, and that is the continued growth of long bones under growth hormone hypersecretion. If, though, the skeletal physes have closed, as they should normally seal after puberty, there are pathologies, though, where there's early sealing. Let's not worry about them right now. But if the physes have closed and there's growth hormone hypersecretion, we call that acromegaly. And megaly is enlargement, and acro is referring to a portion of bone in this case. The most common cause, really, of any kind of endocrine excessive secretion is generally a benign growth of the endocrine tissue. And if it's a benign growth of a gland, we use the term adeno for gland or organ, and growth is oma. So an adenoma for everything, not just this chapter, is the most common cause of hypersecretory endocrine states. So growth hormone, gigantism, and acromegaly most commonly caused by benign adenomas. Doesn't mean there's not other causes, but that's the most common. With excessive secretion of prolactin or hyperprolactinemia, we still see adenomas driving that manifestation, but there's also the interplay with more complicated feed-forward mechanisms from the dopamine system and also from the thyroid. So different hypothalamic or pituitary diseases that alter dopamine secretion or dopamine manufacturing, kidney failure, primary hypothyroidism, which will alter levels of TSH and TRH production, and also taking medications like antipsychotic medications like dopamine antagonists will alter prolactin production. With hyposecratory disorders, it's not as simple as a benign growth. It's a lot more involved, and there's many different etiologies that might lead to hyposecretory disorders. So I just want to then to understand what we're treating with inadequate secretion. It's a little less straightforward with etiologies, but more straightforward with just supplementing a hormone. So with regards to growth hormone, if that's inadequate with kids, what we see is they're not meeting their benchmarks on their growth curves. So we see low age-adjusted growth when we're comparing their height and weight with other children in the population. So they display short stature, delayed bone age, whereas adults, if there is inadequate secretion, we no longer as adults have lengthening long bone. So it's not as easy to see. So instead there's decreased muscle mass, decreased exercise capacity, bone density, psychosocial function, and increased mortality from cardiovascular causes due to stressing the heart with inadequate growth hormone. In prolactin inadequacy, really, you would only see that if lactation is desired, and lactation should generally only be desired by patients after delivery of an infant. Really, when you are dealing with inadequate secretion of a hormone, that's where you're going to see a lot of hormone replacement therapy. If somebody is deficient in something, then we're going to give them that hormone. So starting off with treatment of growth hormone hypersecretion or excessive growth hormone, so either that gigantism or acromegaly. If we just think about the physiology, what we want to do is inhibit things that normally turn on growth hormone secretion. So we might want to mess with growth hormone releasing hormone, or we might want to take advantage of somatostatin. These are already natural physiologic feedback loops that exist, and like most other things in endocrinology, we're going to capitalize on systems that we know and understand. For both of these disorders, because the most common cause is a benign adenoma, that means removing the adenoma is generally the first line of treatment. If for whatever surgery is unsuccessful or impossible to do, then you can move on to radiation of that area to shrink the growth, or pharmacologic inhibition of growth hormone secretion. So this is really a case where we would want to remove the growth. Also think about where the pituitary is. It's inside of the sella turcica, so inside of that bony pocket at the base of the skull. If you have a growth there, there's only enough room in that pocket for the pituitary. So any abnormal tissue growing on top of the pituitary is going to probably crush the healthy tissue. So we can remove it, and we should remove it if at all possible. If, though, you move on to pharmacologic management of growth hormone hypersecretion, you really want to get that person to a level where growth hormone is less than about 2.5 nanograms per milliliter after an oral glucose tolerance test. You also want their IGF-1 to a normal range. Because we know somatostatin, named already for what it does, stop the body, stop body growth, because somatostatin is something that we already know turns off growth hormone secretion, well then why don't we give synthetic somatostatin? And that's what we do. So these medications are somatostatin analogues. Octreotide and Lanreatide are two examples of somatostatin analogues that are available to treat growth hormone hypersecretion. That makes the mechanism of action for both of these medications pretty straightforward. They act in the same way that somatostatin acts in the body physiologically. Somatostatin binds to receptors in the hypothalamus and then shuts down our feedback loop, which promotes growth hormone secretion. The route of administration is subcutaneous, 3 times a day, about 100 micrograms per dose. And this is available in prepared syringes like you would see here. The pharmacokinetics, this is a 100% bioavailable preparation of the drug, which most things that you're injecting are. It's getting right into the system. Peak plasma levels are about a half an hour to see. The half-life of somatostatin and its analogs in the body is about 90 minutes, and an injection lasts about 12 hours. So if you're giving this 3 times a day, you're going to have a lot of overlap with that total half-life. So it should be at a steady level then throughout the day. There is a long-acting release form. That's actually what you see here in this picture. Sandostatin is the trade name for octreotide. LAR stands for long-acting release. So LAR is also available in 10, 20, and 30 mgs. People would take the long-acting once every 4 weeks. So that's once a month. The less somebody has to take a drug, the better the compliance. Our second somatostatin analog is Lanreatide. This is very similar to octreotide. It was just created second, so that's why we talk about it second. One of the medication names that it's sold under is right here, and you'll see Soma right there, Somatuline. The other thing in there that will help you know that it is Lanreatide is Autogel, which stands for self-gel. Autogel does not mean that it's given as a gel that you squirt into your mouth. Instead, it is referring to this being in a thicker medium, meaning that it lasts longer in the body. So it's more of a depot type injection. But it works in the same way. It is a somatostatin analog. Because it's a little bit thicker, it's more gelatinous in its suspension. It's also a deeper subcutaneous injection, also given once a month or once every 4 weeks. 100% bioavailable, works for that full 4 weeks. And when we look at clinical data with effectiveness, it is exactly mapped onto the efficacy of octreotide long-acting release formulation. I want to also mention this drug really quickly. It is called Posteriotide. It is classified along with the other somatostatin analogs. However, again, remember how I said how the cells in the anterior pituitary, even though we teach them like they each do their own thing. If it's a thyroid cell, it does thyroid stuff. If it's a lactotrophic cell, it does prolactin things. Well, they kind of look similar and they can bind other things. It turns out Posteriotide is not best at dealing with growth hormone excess. It's actually best at dealing with cortisol excess, which means that it is used in Cushing's disease, where you have a hypersecretion of cortisol, because truly there's hypersecretion from the level of the hypothalamus and pituitary. So it actually targets ACTH, adrenocorticotropic hormone, and blocks ACTH, which means it's really helpful in treating Cushing's disease. It has been FDA approved to treat acromegaly, and when you look at the clinical data, it actually outperforms octreotide LAR long-acting in clinical trials. So it is a possibility, it is FDA approved, and it does have good efficacy. So when we're thinking about treating growth hormone hypersecretion, we give substances that look like somatostatin analogues. Adverse effects of SST analogues are the same across the board. GI distress in about half of people who take them, including nausea, diarrhea, and abdominal pain. A quarter of patients who take any of the three develop usually small gallstones. We do see a small amount of patients also exhibiting slow heart rate and QT lengthening, but generally they already have an underlying cardiovascular disease. These medications also decrease insulin secretion. However, they are associated with less resistance to insulin, meaning that receptors don't get sick of attending to the signal of insulin binding to a tissue. So it's kind of like when you smell something, after that odorant binds to its receptors, the 1,000th time, and your brain is like, okay, you smell like a rose, I get it. It stops attending to that signal. And that's called resistance. It kind of gets tired of it. So we do not want insulin resistance. We want our tissues to respond to when insulin binds. So there's less insulin resistance, and that's good. That's great. In rare cases, there is the possibility of hypothyroidism, so just remember to regularly test the thyroid. Because Posteriotide is medication for treating Cushing's, know that if you're not using it to treat Cushing's, and you're maybe using it for acromegaly, that you can expect that it lowers adrenocorticotropic hormone and cortisol output. Again, that's what you would want if you're treating Cushing's. But generally, if they didn't have an abnormality, you will see low cortisol in the blood. It also decreases some hormones we'll talk about in the diabetes medication chapter, GLP-1 and GIP. GLP-1 turns on insulin and turns off glucagon. GIP turns off insulin and turns on glucagon. So they have opposite jobs. But both of them are decreased with somatostatin analog posteriotide, so glucose tolerance does get worse with that medication. So definitely keep that in mind, but also keep in mind that it's going to have those Cushing's effects, which are desired, and that's why it is used to treat Cushing's. All right, another way that we can turn off growth hormone is to use an antagonist. If there is something sitting in the receptor site for growth hormone, well, then growth hormone can't bind. Pegvisomant is an example of a growth hormone antagonist. It's a pretty big substance, and when it sits here and blocks the growth hormone receptor, poor growth hormone, look how sad it is. It has nowhere to bind. So very simple mechanism of action. It's a growth hormone antagonist. Somavert is the name for its injectable, which is sold by Pfizer, and it's a 15 mg sub-Q injection sold in individual vials or premixed syringes. So its mechanism of action is simple antagonism of the growth hormone receptor. If you antagonize the growth hormone receptor, you're not going to promote more growth hormone release. Route is subcutaneous. There is a loading dose, meaning you start with a high dose, get the blood levels really high, and then maintain the plasma levels for the rest of the treatment. And that's called a maintenance dose. So loading dose is 40 mgs, maintenance is about 10 mgs a day, and titration, meaning adjusting of the dose, occurs at about 4 to 6 week intervals. Contraindications and adverse drug reactions. There are liver enzyme abnormalities possible, so it's important that you're monitoring liver enzyme levels. You can also see lipohypertrophy, so fat excessive growth or excessive substance. So that means that fat grows big at the site of injection. And that's kind of predictable if we think about the physiology. Growth hormone encourages adipocytes to break down their fat so that we can utilize it. If you're injecting growth hormone antagonists into an area, we're going to see immediate local reactions on the fat there. So that's lipohypertrophy. Moving around injection sites is one way to make that a little bit less noticeable. Also, because the body really wants to see growth hormone and at least IGF-1 as well as its negative feedback, if you are giving an antagonist, you are going to mess up the negative feedback loop. So that means if growth hormone mechanisms that already exist in the body to maintain homeostasis get the message that there's low growth hormone in the body, that will signal to the hypothalamus and pituitary that they need to work harder to make more growth hormone. Meaning, if there is any kind of adenoma that is secreting that growth hormone, that can drive it to grow. So it does feed both benign and malignant tumors. It's important to monitor with an MRI to make sure there is no tumor growth. All right, now we're still on hypersecretion, but we're moving on to prolactin hypersecretion. This is a good picture showing you everything that can mess with prolactin secretion. And there's so many things because we have mechanoreceptors and we also have hormonal things and then also neurotransmitter things. So we can have polycystic ovarian syndrome, different pituitary tumors of the stalk, of the lactotrophic cells in the pituitary. You can have reduced elimination of prolactin because of liver failure or kidney failure or just low function, so it builds up in the bloodstream. Pregnancy, well, guess what? You get a lot of estrogen for that, which is going to drive prolactin creation. And when prolactin is released in the body during pregnancy, that helps drive the milk ducts to proliferate. So the breast size goes up because the body is preparing for nursing. And prolactin is really important for that branching and differentiation. Then we have things that affect the mechanoreceptors, because mechanoreceptors stimulation turns on and turns off prolactin secretion. So if there's an injury to the chest wall or any of the nerves that supply the area of the breast, that can alter prolactin secretion. Then you cannot forget that we also have dopamine, which is inhibitory upon prolactin. So if we're giving anything that would mess with dopamine expression, so either increasing dopamine, so things that make you feel good increase dopamine, like opiates do, alcohol does, anything that chocolate cake does, and then things that block dopamine like neuroleptics, antipsychotic medications, those can alter expression as well. So it's a very wide spectrum of things that can cause excessive prolactin, but like every other thing, an adenoma is the most likely cause of hypersecretion. And not only can we use the term adenoma or gland growth, we can also use the term, to be super specific, prolactinoma. So that is specifically referring to a benign growth of prolactin secreting cells in the pituitary. All right, so who cares if you're secreting too much prolactin? Well, everybody. When there is lactation from a non-pregnant breast, we refer to that as galactorrhea. So that's one thing. When males are lactating, they don't love it. When females are lactating and they're not pregnant, they don't love it. When you give medications where that's a side effect, it's a worrisome side effect, and people generally don't enjoy that. The other thing to keep in mind about prolactin is one of the ways our body evolutionarily makes sure we, as breastfeeding mothers, put all of our energy into feeding our newborn is to make sure that if there's a high enough level of prolactin in the bloodstream, so for the first 3 months after delivery, prolactin is really high. Prolactin is so high that it actually works as a birth control. It works as a contraceptive. So prolactin at high levels is inhibitory on ovulation. So the body does this in early life of the newborn so that the body's energy is all going to lactogenesis, which will feed the newborn in the period of time where they're growing the most. After milk production levels out, after that 3 months, prolactin levels start to drop unless there is feeding certain levels of the day. It's usually 8 or more times a day where there's a lot of nursing. Prolactin levels will drop, and then ovulation will eventually go on again. That means if somebody is attempting to get pregnant, if they have hypersecretion of prolactin, they will not be able to get pregnant because of the way prolactin works to inhibit ovulation through the HPG, or hypothalamic pituitary gonadal axis. So we want to fix this not only to get rid of galactorrhea, but also to allow pregnancy to occur in somebody who has too much prolactin and it is inhibiting that response. Because dopamine physiologically inhibits prolactin secretion, we can take advantage of that knowledge by altering dopamine levels or dopamine release to allow levels of prolactin to be decreased. So we're taking something we already know. We're taking our knowledge that dopamine decreases prolactin. And if we have too much prolactin, we might want to increase dopamine activity so that we can ensure that prolactin isn't secreted. The inhibitory receptors in the body generally have an even number associated with them. So the medications we use to target the dopamine system to decrease prolactin in hypersecretory states is called the D2R, or the dopamine type 2 receptor. So we give medications that stimulate an inhibitory receptor. So what we are doing is promoting the inhibition of prolactin. And in this case of prolactin excess, even though we generally have adenomas that drive hypersecretion, the D2 or agonists are so effective that surgery and radiation are recommended to patients who usually don't respond to these medications or, for whatever reason, cannot take them. That means surgery, radiation is not the first treatment like we would see with growth hormone. In the case of prolactin excess, the first choice are dopamine agonists. All right, the first dopamine agonist we'll talk about is the first one to be created. It's called Bromocriptine, and the trade name that it's sold under in the United States is Parladel, and its mechanism of action is a D2 agonist. Because this is the first one, usually the first time we make a medication, it is not the best form of it, and that is definitely true for this. We would love if it was specifically only stimulating the D2 receptors so that we get general inhibition in the system. However, bromocriptine also hits the D1 receptors. That's important. Remember that for a little bit. But anyways, this was the first one, and anything else that's created is compared to bromocriptine or Parladel. So it's our dopamine type 2 agonist that kind of also hits D1 receptors. It is taken orally, but it can also be taken in the form of a vaginal suppository. This medication undergoes really significant first pass effects in being broken down by the liver before it reaches its site of action. So only 7% actually makes it to the systemic circulation. Its half-life is 2 to 8 hours, and it's divided into 2 doses. And even though that's less than, a day, and not covering the full day if it's only 2 doses and it's working for 8 hours, giving it twice a day seems to be sufficient. The vaginal suppository will bypass that first pass effect generally because of the routing around our portal system. So you do have more drug that's preserved that way, and you'll have a little bit more in the circulation. Adverse drug reactions, most common and expected, would be GI, so nausea, vomiting, but then there's also headache and postural hypotension, which is feeling dizzy or actually fainting when you change position, so when you stand up from sitting or from lying down. That's more common when you first start taking the medication, especially the very first time somebody takes that medication, and kind of wears off with time for some people. Less common side effects, nasal congestion, digital or finger vasospasm. So that would look like blushing or blanching of the fingertips. And then remember that D1 thing too? One thing that is special about bromocriptine, because it does hit the D1 receptors, and when you hit D1 receptors, that really, really makes a ton of dopamine. And when you have a lot of dopamine, that's what psychosis looks like. So you see psychosis, which is believing or experiencing things that might not actually be happening, or experiencing emotions that are out of alignment with what would be considered neurotypical. Hallucinations, which is seeing, hearing, smelling things that are not there, nightmares, and then difficulty sleeping. Those CNS effects, they're important to keep your eye on. Generally, most people respond to a decrease in dose of bromocriptine, or they can be switched to the next medication we talk about. With using bromocriptine, it does reduce prolactin in 70 to 80% of patients who take it. It also decreases the size of the adenoma of prolactin secreting cells in half of patients. When you do take them off of this medication, it is normal to see regrowth. So as they're taking it, the tumor will get smaller, the benign tumor gets smaller, but when you take them off, it does get larger again, and they will continue to hypersecrete prolactin. This medication, because it affects the dopamine system, is really important in the treatment of Parkinson's disease, which is a hypodopaminergic state, and also with blood sugar metabolism or glycemia in type 2 diabetes. Our second dopamine agonist is Kabergaleen. This is the second medication that was brought to market, sold as Dostonex in the United States. Because it is the second one to come about, we can refine things and make it better. So this medication is different than bromocriptine in that it is selective to the D2 agonist. So you will not see CNS effects with this. And if you had a patient experiencing those with bromocriptine, this medication will ensure that they should not experience those again. Generally, though, it works relatively the same way, but another benefit is that there's a far less likelihood of GI side effects also, so that like nausea and vomiting you would see with bromocriptine is less likely with Kabergaleen. This is an oral med, 0.25 mg twice a week or half a mg once a week. You can increase this by about 1.5 to 2 mgs 2 to 3 times a week. You only want to adjust this every 4 weeks because of the half-life. The half-life for this is 65 hours, which is way longer than 2 days, right? Yeah, not 3. Let's not do math right now, but high first pass effect, long half-life, so that 4 weeks ensures that you're getting the stable blood level that you want when you're testing to make a judgment about whether or not to alter a dose. So as I mentioned, less nausea than bromocriptine. You will not see the CNS effects because it does not hit D1. It is specific for D2 only. You will still see, though, the hypotension and dizziness, so that low blood pressure, possible postural hypotension. At very high doses, this is associated with valvular disorders of the heart. A good thing about this is that those high doses are usually only used to treat Parkinson's disease. The levels to just treat prolactin secretion by itself generally do not reach that level. So we don't have to worry if we're staying within bounds of dosing about seeing those valvular heart issues. All right, and then we'll finish up with deficiencies. So first off, we have growth hormone deficiencies, which, again, with kids, that's easier to see. They're not meeting their growth curves, right? They're not getting taller. Their bones look different. Their muscles are small. And this is an easy example of using hormone replacement therapy. And substituting growth hormone in pediatric patients is a cornerstone of therapy. It's one of the most popular reasons why hormone replacement therapy is done, and it's long-standing, and it's been used for a very extended amount of time. What's newer is using it with adults. So this is a graph showing you AGHD, which stands for adult growth hormone deficiency. And this is showing you an algorithm for what kind of doses you would want to put somebody on of growth hormone replacement. So it is going to differ in dose depending on somebody's age, whether they're men or women. So they've already gone through puberty at this time. If they're adult. So their physes are closed, and the skeleton's going to be a little different, so doses will be altered. We've got our dose titration here and what kind of measures you want to look at, like blood pressure, BMI, waist, circumference, and what you should be looking at every 6 to 12 months, 12 months, and 24 months. We want to see if the bones are growing, what their body mass looks like, and what their bone density looks like. In addition to other metabolic markers, because GH, that increases metabolism and anabolism. So it's anabolic and it's metabolic. So the science term for growth hormone is somatotropin. Soma means body, and tropin comes from tropic, which means increased growth or activity. So body growth, somatotropin, great name. So we are going to supplement growth hormone with an analog of somatotropin, our synthetic growth hormone. Mechanism of action then is easy for this disease. It is growth hormone. It's just an analog of it. This fun fact, humans, we do not respond to growth hormone from any other animals. So you cannot take cow growth hormone, like bovine growth hormone. We don't get the same effects from it. So if you hear about people taking it on purpose, like for performance enhancing reasons, like in the Tour de France, for example, they usually call it human growth hormone to really let you know that this is not from another animal. So once we figured out that we couldn't get growth hormone from animals, the first thing we started doing is purifying it from cadavers. Unfortunately, that was linked with a pretty widespread breakout of Creutzfeldt-Jakob disease. You may associate that with the term mad cow disease. That is a spongiform encephalopathy, which is really progressive and terminally fatal, and it either comes from coming into contact with tissue that's been infected or from eating contaminated meat. This is where that mad cow disease term came from. If a cow or bovine has that disease and we come into contact with something that is infected, then it passes really readily. So we found that if a cadaver had purified growth hormone from it, we could also get some of the diseases from that host. So there was a pretty widespread outbreak of this disorder, which leads to really rapid onset dementia and motor issues and amazingly marked brain changes that's ultimately fatal. So now we use DNA recombinant technology to make our own human growth hormone. Mechanism of action is the same as growth hormone. It does growth hormone things. It looks like growth hormone. It is given by injection because it's a peptide hormone. It is not stable in stomach acid, so it needs to be injected. It's generally given sub-Q, 70% bioavailability, and the dose you're going to use is different depending on age, sex, and which disorder you're treating for. Pharmacokinetics of growth hormone are very short. Naturally, growth hormone is released in a pulsatile nature. Its highest level of release is about 2 hours after you get into deep sleep. So sleep is super important with body repair. That's because of growth hormone release. So it naturally has very short acting kinetics. The activity is a little bit longer than just its normal half-life in the body. So it's dosed usually just once a day, even though it's got a short half-life. Our body knows what to do with it. Adverse drug reactions in pediatric patients, intracranial hypertension is something we need to watch out for, which would manifest in the eyes first. So you want to do fundoscopic exams to check out the retina, check out the back of the eye, and make sure those vessels have integrity. Adults, if you're giving too much growth hormone and they've got closed skeletal physes, then you're giving them acromegaly. So they're going to experience those symptoms you would see with that pathology, which would be peripheral edema, carpal tunnel syndrome, arthralgias, which is joint pain, and myalgias, which is muscle pain. Contraindications, you try not to give growth hormone to somebody who is very sick or just had a major surgery because it can cause heart failure and respiratory failure. If there are multiple accidental injuries or trauma, or there's also case studies of severe obesity leading to death because it really overstresses the body. So you want to make sure they've got a healthy heart, their body is not compromised, and their lungs are working as you would expect them to. If you give a tumor growth hormone, it's going to get bigger. So you never, ever, ever use growth hormone with growths. Benign growths, malignant growths, they're both going to get bigger. Malignant growths will get bigger a lot faster. So we avoid in any type of cancer and with adenomas. All right, so this isn't part of most textbooks because it is so outside of the class of drugs that you would expect. But in the case that somebody wanted to increase their prolactin secretion, there's only one time where you'd really want to do that, and it's when breastfeeding of an infant is desired. Generally, if there's not pregnancy, we don't want prolactin secretion. So we're looking at one specific population. After giving birth, they have low or very no milk production. The medications that are used to increase breast milk have nothing to do with the brain in the way that we would expect. The medications that are used are actually GI medications, domperidone and metoclopramide. These are both spasmodic medications, and they're sold as motilium, which should help clue you into like motility. This increases motility of the GI tract, so it's useful in constipation, for esophageal disorders, for gastroparesis. Turns out that when you give domperidone or metoclopramide, these also increase milk production. So if somebody was having trouble expressing milk, you can try either one of these medications, and you give about 10 milligrams every 8 hours. And after the milk is well established, which may be very quick in just a couple of days, or it may take about 3 weeks to occur, then you can stop the medication or decrease to maybe, once a week in some cases. What you're looking at here in this graph is just mean milk production. This top line is domperidone and the bottom line is metoclopramide. See, again, these are two spasmodic medications, so usually used to increase activity of the GI tract. We can see that milliliters, literally milk milliliters, so in its liquid measurement is increased with both of these, and we do have more milk that's associated with domperidone. This is also not in a textbook. If you talk to somebody who had to take domperidone, they do complain about their milk smelling more like maple syrup than you would expect milk to smell like. So much so that at least women that I know avoid delicious breakfast foods because it smells like maple syrup, which reminds them of taking domperidone, and they're now averse to it. But another example of pharmacology surprising us, 2 GI medications are the 2 major treatments that we can use for lactation. And that, my friends, is our pituitary disorders, both hypersecretory and hyposecretory pharmacotherapeutics lecture. All right, everyone, I hope you learned something. Stay smart.